Awesome. It's great to be here. Thank you very much. Thanks, George, for that great talk. Also, thank you to myself for not having lunch before having watched some of those videos. I'm really excited to be here and talk a little bit about whole body screening. So my journey started about 6 years ago. Like many of you in the room, I'm an entrepreneur. And like most entrepreneurs, I didn't sleep enough. I was stressed. I didn't have a great diet. I didn't exercise very well. And I remember waking up one day and looking in the mirror and asking myself this question: I'm working so hard to build a better future for myself. How do I know I'm going to be around for that future? And about the same time, I took my car in for a checkup. And 3 hours later, I got this tremendously comprehensive report. It went through every component of my car. It told me things that were broken I had no idea about. And it told me how my erratic driving was, unnaturally wearing the brake pads on my car. And I thought to myself, this is crazy. How is it I know more about the asymptomatic health of my car than I do about the asymptomatic health of my own body? And as a society, in fact, we spend about 4 times more money screening our cars every year than we do screening our bodies. And my body, sort of 6 years ago, so the mental image I have is if it was an airline, I don't think any of you guys would be flying sort of Andrew Air. If you got in and looked in the cockpit, there's no instrumentation whatsoever. Hopefully arrive at our destination, but more likely than not, an engine's going to explode along the way. And as the plane's hurling down, the only promise I can give you is that a whole team of medical professionals will jump out and hopefully fix that engine before we crash into the ground. Frankly, I don't trust myself, and I don't really trust any of us to live our best lives in this sort of instrumentless health system. And there's lots of reasons for this. You can see some of these on the screen. But let me introduce you to Ryan Crownholm. He's a patient that we screened a couple of years ago. He's an Army veteran. Unlike me, he was super fit, ate well, had a six-pack to die for. He came in for a screening expecting nothing wrong. What we ended up finding was an 8.5 centimeter kidney cancer that was graded stage 3. Now, he had no idea about this, did not expect this finding. And he's frankly not unique. Every single person in this room knows someone, a loved one, a family member, a relative, a colleague, who was 100% healthy until, in an instant, they weren't. In fact, in the UK, most cancers are caught on average at stage 3. And more than 50% of those are caught when a patient presents at a hospital with acute symptoms related to that cancer. And unfortunately, I think there's a lot of disparities of sort of health outcomes in our system here in the UK and also around the world. But the biggest disparity, I believe, relates to how quickly you can get diagnosed with a condition, because we know if you get diagnosed early, it's going to lead to better outcomes for everyone. Chronic disease is about 80% of what we spend health system dollars on. And what I find really curious about the word chronic disease, you'd think it would mean disease that has become chronic. But actually, it's not. Most chronic disease is defined by being chronic from the very beginning. It's almost as if the disease didn't exist before it became a chronic stage. It's like it wasn't there, and we all know that that's not true. We know that underneath the skin, if we only looked inside, we could tell a different story. A simple example of this is dementia. If I went to my doctor and said, hey, I want to get checked, I might have asymptomatic dementia. And they would probably laugh at me. That doesn't exist. But we know from imaging over 100,000 patients now that we can see loss of perfusion, thinning of the corticals, brain volume loss, often decades before a patient presents with clinical symptoms of dementia, at which point they've already lost 30% of brain volume in the hippocampus. If you ask a patient who's lucky enough to survive a burst aneurysm, or cerebral or aortic aneurysm, about 1 in 10 people survive those. Why on earth didn't you do something about this before? And they'll laugh at you and say, well, I had no idea that I had this condition. When we only have one life, so we all age, but how do we know whether the aging that we're all experiencing is normal aging or abnormal aging? On the screen here, we have an AI model that we train to predict someone's biological age based on features in their spine. And when we published this model, we thought there was a mistake because the model did a really bad job at predicting the biological age of anyone between the age of 20 and 35. Regardless of your age, everyone looked like a 35-year-old. And we went back and we thought this was a mistake. We showed a whole bunch of radiologists and we said, why is this? Please predict the age of these patients. And the radiologists also couldn't tell the difference. The average 20-year-old spine looked like the average 35-year-old spine. I don't know why that is the case and what's happened in the last 15 years that might predict this. But the crazy thing is, these patients, these very young patients, might be feeling slightly symptomatic, but they had no idea what they were experiencing was abnormal aging. And the interesting question is, what will those patients be like in their 50s and 60s? Because we know loss of mobility is so closely linked to longevity. And just knowing about this today could make a huge difference in the outcome and the trajectory of that potential future disease. Finally, our bodies are built with such tremendous redundancy. And we see this when we scan patients at Prenuvo. We'll see patients that have a kidney that's atrophied and the other one just sort of grows bigger and takes over. We have this redundancy which masks symptoms from us. And the body just sort of keeps going until at one point it reaches a point of no return and we have sort of precipitous decline. Now, I used to live in the UK 10 years ago, and a big thing in the US right now is consumer blood testing. And I remember when I was here 10 years ago, it was a big thing in the UK, so you guys are actually sort of ahead of the curve. And I signed up for one of these services and I got a blood test, I think every month. And what was really interesting about these tests is they were only secondarily concerned with whether or not I had an abnormal blood marker. What they were concerned was, as we measured every month, what were the trajectory of my blood markers? How was my cholesterol changing month to month? And the idea being here, if we can spot a concerning trajectory early, we can do something about that. If you don't measure it, it's really hard to change it. So this is a little bit what Prenuvo is doing through imaging. So for those that don't know exactly what we do, I think the introduction, Greg, was great. It's a 40 to 45 minute scan. It's a clinical diagnostic MRI examination. We go through the body from head to ankles. We review 33 different regions of the body. We assess for 500 conditions, including solid tumors at stage 1 and aneurysms, and then ideally finding at a very early stage those diseases that one day could become chronic conditions for the patient. It's not a test that we do, it's sort of a clinical practice. We have our own clinics in which we put research-grade MRI machines. These MRI machines in 45 minutes can image what in a normal outpatient imaging center would take about 3 hours. And really, to be honest, that's what enabled the exam, because no one wants to sit in an MRI machine for like more than an hour. Every month, we sort of continue to update and optimize the protocols for image acquisition, and we have a lot of AI that's working under the hood to make sure that we can acquire images as fast as possible while still maintaining clinical quality imaging. I have a whole team of radiologists, about 100 people now working with us. These are people that hail from some of the best academic medical institutions around the world, and they all joined us because these people became radiologists to save lives, and too often radiology is involved very late in the sort of treatment of a disease. So here, for the first time, they're able to make diagnoses that can have a real impact on people's lives. We also do blood. Blood helps us identify some conditions that we can't see early with MRI, and also helps us make what is already a pretty accurate reading even more accurate by providing critical information about these biomarkers. And then finally, we do all this inside our own clinics. We wanted to create an environment that's not anxiety-inducing for patients. We've been conditioned by this reactive healthcare system to be nervous about learning things about our health, and we didn't want to trigger any of that conditioning. What the patients receive at the end of the day is a very detailed MRI, a detailed sort of set of images of their body, and an app and a website where we go through every condition, what we see, what we don't see, and most importantly, what you should do about it. Now, there's a lot of common questions about questions that come up all the time about whole body screening. I want to try and answer some of those very quickly. So, false positives. Most people are talking about cancer when we talk about this. We don't diagnose cancer with MRI. What we do is we look inside the body for lesions, and then we grade them according to an emerging standard called OncoRAS that we're a part of developing. The goal here really is to get really, really good at being able to see something in the body and knowing whether this is benign that you shouldn't worry about or something that's concerning you should do something about. And the results so far have been really, really interesting. For patients that get a biopsy after a Prenuvo scan, 56% of those biopsies end up being proven as being cancer. And by way of reference, that's better than the positive biopsy rates of most standard of care screening, which is pretty incredible given that we're looking for cancer everywhere in the body. 64% of those cancers are early stage cancer, and 68% are cancers for which there is no standard screening test. Great examples of these are ovarian cancer and pancreatic cancer, which are typically caught, unfortunately, at a terminal stage. In terms of anxiety, what we sort of forget is that probably 1 in 3 people in this room, on average, are already anxious about their health because our health system doesn't really provide you with a lot of insight into how it's going. For every 1 person that we make anxious about their health, there's about 50 that we give peace of mind. So we're in the business not of creating anxiety in some ways with these scans, but if they're done right, you can actually reduce anxiety in the health system at large. What's kind of interesting, by the way, is we don't just reduce anxiety by telling people they have a clean bill of health. There are a ton of people out there which we deliver not great news to, and they're happy that that news has sort of ended a period of uncertainty in their lives about their health status, and they can actually do something about it going forward from there. And then finally, overdiagnosis. We heard from Dr. Sullivan this morning about sort of like concerns around overdiagnosis. I guess I'll take the opposite side here. I don't think overdiagnosis is a problem. That's just information. The 2 problems downstream of that is, 1, that shouldn't lead to overtreatment, and we try really hard to contextualize the findings that we give patients so that people don't end up in this sort of cascade of tests and care. And secondly, also how you feel about the information that you receive. When you have a healthcare system that only catches disease late, we all sort of end up fearing ever having anything caught. And I think so I tell my team sometimes what success looks like for us is not that we've sort of like, it's not the number of people we're screening, it's whether we change the definition of disease from something that's scary to something that's empowering. We're running a big clinical trial in Boston, Massachusetts right now. So some early results we'll be publishing later this year and early next year. About 1 in 20 people have a potentially life-saving diagnosis. These are people that are asymptomatic. And about 20% end up crediting us with really making relatively significant lifestyle changes as a result of something that they found out on a scan. All in all, 92% of people having done a scan want to continue doing these scans every year as a way to stay on top of their health. So finally, just the wider context. I'm sort of excited to be here and part of this event, mainly because I think this is a really interesting time for preventative health and proactive medicine. Consumers are increasingly wanting to take charge of their health. We have imaging, we have liquid biopsies, we have blood testing, we have genetics, we have epigenetics, we have hormonal testing, we have environmental testing, and so on. Consumers are really embracing it. Investors are flocking to this space. It's a really great time to be seeing all of this innovation. Many things will succeed, some things will fail, but I think no one's been talking about proactive medicine more than they are talking about it now. In some ways, what we as consumers are doing is we're living our own sort of moonshot. And in health, we talk a lot about moonshots, but we aren't really good at executing against them. Well, here's a whole bunch of consumers that are sort of in some ways trying to live the health experience that they wish the health system provided. And sort of when I think about this, the sort of mental image it creates is this idea of sort of climbing a mountain. And I think in healthcare, we spend a lot of time sort of doing all this optimization. We're sort of trying to get higher up this little hill, when really I feel like we should be actually climbing this other mountain over here. And it's a critical challenge for us as an economy. And to be honest, there are more similarities in health systems around the world than there are differences. A lot of people like to point out the differences. About 20% of GDP everywhere in the developed world is spent on healthcare. And with aging populations, that will become 50% in about 15 years' time. So we need to really spend a little bit less time optimizing over here and really be working hard to figure out, well, what is a transformed healthcare system? What would that look like? What would a system be like where disease is diagnosed early, where we don't spend 80% of every dollar on treating people with late-stage chronic disease? That's the world that I would like to create, and I'm excited to see other companies sort of embarking on this journey as well. And I think Not all, like all moonshots, not all the answers are sort of readily apparent when we start off on that journey. But I think, if we don't, this is the only way I think we solve healthcare and lead to better outcomes for individuals and for the economy writ large. So thank you very much for your time.
Thank you, Andrew. You talked about it being a moonshot. So I guess my first question would be accessibility, both sort of like geographically and financially. Obviously, you want to scale. Like, how are you thinking about that process?
Yeah, well, when we first started this, there were a few other people that were doing whole body scans in the US, and they cost something like $50,000.
Right.
And in fact, people with cancer predisposition syndromes in many health systems do have access to these scans, but they are very, very, very expensive for the health system.
Yeah.
So when we started these, when we started offering these in the US at $2,500, it was sort of 20 times cheaper. The goal eventually is $500. But of course, and I'm going to probably anticipate your next question, that involves an awful lot of AI, because certainly the biggest expense in running this wonderful service are the wonderful radiologists that spend so much time doing these readings.
Yeah.
And the future, hopefully, is one where AI is taking a lot of that load.
Presumably, if you're based though in the US, that involves partnerships with healthcare systems, insurance companies. I know you said that people sort of focus on the differences between healthcare systems, but obviously we've got a public healthcare system here in the UK that's sort of like financially challenged. Obviously, downstream there would be huge savings, but then you have that initial investment. Like, how can you work, do you think, with the...
Well, we do it by really studying it as best we can. So we're running a clinical trial that's 100,000 patients.
Yeah.
We're following their health over several years and hopefully collect evidence for health systems to make better decisions.
Yeah.
And then every patient that comes in today really is part of a clinical trial.
Right.
Where we're collecting that evidence on an ongoing basis. So the patients that pay today, in some ways, are funding for, I think, hopefully, an insurance-paid option in the future.
Yeah. And how are your patients, how are you helping them understand and act on what they learn from the scans that you're working with them on?
Well, we don't just give them a report and sort of send them off into the world. We have medical practitioners that sit down with patients and go through those findings and really try hard to contextualize what we are telling patients so that then they can go out and engage with their own medical teams and health systems sort of as an equal.
Yeah, brilliant. Well, Andrew, thank you so much for sharing that. Super, very, very exciting kind of work you're doing, and we're looking forward to hearing more about it in the future.
Thank you. And we're going to be opening in London in a few months. So
whereabouts?
In Fitzrovia.
Fitzrovia, all right.
Yeah.
Well, not too far from here. So once everyone's finished at George's party,
we will invite people over for beers when we open.
There we go. All right. Thank you so much.
Thank
you, Andrew.